keep us on track and not get on Marwin's bad side so early. I have the fortune of coming all the way from Durham to Houston to introduce a colleague from Durham, the famous Sunil V, who talked to us about challenges in implementing and designing cardiogenic shock clinical trials.
Great. Thank you, Jason. Thanks, Marwan, for the invitation. It's a real honor to be here. I tried to get Jason to become an interventional cardiologist, but he's too smart doing that. So, I think that first talk was really a great introduction to what I'm going to talk about, which is challenges of clinical trials. And I'll tell you, I'm actually a little more sanguine about the prospect of doing trials. I think we have to be a little bit careful, relying on observational data because we've been led astray so many times before. And I think, just to sort of point it out, there have been 3 large propensity-matched analyses comparing different mechanical support devices that are almost certainly confounded by indication, and potentially you're getting the wrong answer. So I do think that it's incumbent on us to generate these clinical trials. I actually don't have any relationship with industry. So here's what I'm going to talk about over the next few minutes or so, a lot of which you've already seen. What do we know about shock so far? I mean, despite the fact that there are challenges to doing clinical trials, there are some clinical trials that are available, and I think they have been helpful in guiding us to manage patients with shock. Having said that, these randomized clinical trials all have weaknesses, and so they are not laws. They're not something that you're going to have to adhere to for every single patient with shock. So there are nuances around these. And then, we'll talk about the trials that have been completed, and then we'll end with what the challenges are, some of which we've already talked about during the panel discussion, but I hope to have a little bit more discussion about how we can address those challenges. So what do we know? Well, one thing we know is that the incidence of shock has been relatively stable. One could argue that it's getting worse. But overall, we have some strategies that we've applied, primarily revascularization. So in the era of primary PCI, we don't see a lot of acute MI cardiogenic shock, certainly not as much as we used to. The other thing that hasn't changed much is the in-hospital and 30-day mortality. It's still around 30 to 50%. So that's really the challenge that we're facing when we have a dearth of data, is the fact that these patients, when they do come in, ultimately have a terrible prognosis. And now we're talking just about mortality. We actually have absolutely no idea what their functional outcome is. So we don't know how many of them end up completely disabled. We don't know how many of them end up with some kind of long-term care. And I would argue we actually also don't know what the effect is on their caregivers when they're discharged from the hospital, if they survive that hospitalization. So while we're all talking about mortality, and that's entirely appropriate because of how high the mortality is, we don't know what the functional outcome of these patients is either. We do know that there are some strategies that we can use, and I'll talk about what those randomized trials are, but when you think about acute MI cardiogenic shock, which is something that I see, which is really sort of my sphere because I'm an interventional cardiologist, I don't live in the heart failure world, we have a sense of what the pathophysiology of that particular entity is, which is the occlusion of an epicardial coronary artery, which leads to myocardial ischemia. And if you were part of the teach session this morning, which I always learn something when I attend the teach sessions, you sort of understand what the spiraling cascade of events that leads to end-stage shock and oftentimes mortality in these patients. So this tends to give us a little bit of a sense for what our priorities are when we treat these patients, which is immediately trying to get that artery open. Now, when you do that relative to when you implement mechanical support is something that's undergoing randomized clinical trials right now. So we'll have a little bit more information about that. Do you support the patient first, then open the artery, or do you open the artery first and then support the patient is something we'll have some answers to. I'm not going to go through the hemodynamics of shock because I think you had a pretty big session this morning about that. But at the end of the day, we sort of know what we're dealing with the patient in front of us. We're dealing with a patient who does not have enough blood pressure to perfuse their end organs. And therefore, our priority is to try and reverse that cascade and to try and deal with the fact that their left ventricular end-diastolic pressure is increased, their overall cardiac output is decreased. How we do that is really the subject for the randomized trials. Do we use inotropes? Do we use vasopressors? One could argue that they're the equivalent of embalming fluid. Do we use mechanical support devices? We don't know exactly if we should. Our gut tells us that we probably should. When should we use them? These are the questions that we need answers to. Now, one thing that I think is really, really exciting in the era of big data. So what is big data? I had one of the most famous health services researchers at Duke tell me that big data is whatever he says it is. But what is big data? It's really just a tremendous amount of information that's being collected in the course of clinical care, right? Now, how many of you are big fans of Epic? Yeah, and of course, nobody's a fan of Epic. But one thing it does do is it collects a lot of information. And the promise of the electronic health record was to use that to try and create decision support. But this is a really exciting study from Naveen Kapoor, who's been in the sharp end of the spear on this stuff, where they applied machine learning to 3 different data sets of patients with cardiogenic shock: the Cardiogenic Shock Working Group MI cohort, the CHF cohort, as well as the Danish registry, and applied the machine learning and artificial intelligence to these data sets to try and come up with clustering of phenotypes. And what they found was that in this large body of data, there were 3 clusters of phenotypes: the non-congested shock, the cardiorenal shock, and the cardiometabolic shock. And they all shared specific clinical features. And I'm sorry, this may be a little bit tough for you to read, but you can see here that they all shared decreased blood pressure, because again, they're all in shock. The phenotype 1, the non-congested, didn't have evidence of congestion, hence the definition, but the cardiorenal had mostly left ventricular dysfunction, and the cardiometabolic had mostly right ventricular dysfunction. I'm not going to go through this entire table, but I encourage you to look this particular study up. It's really a terrific study, and I think really where we need to go when we start collecting these data is to apply these machine learning techniques to try and figure out the phenotypes that we deal with in the shock world. And interestingly, when you look at these 3 different phenotypes, there seems to be some relationship with mortality. So the patients who have cardiometabolic shock, for example, had the highest mortality relative to those who were non-congested. Now, this may be just a marker of when these patients came to medical attention. So it may be, again, an argument for us to deal with these patients early on. Either way, it's really fascinating when you start separating these patients out based on their clinical presentation and ultimately what happens to them. And hopefully, these kinds of data will help us figure out when to intervene and what kinds of interventions we should be doing. So what are our strategies for acute MI? Well, again, we have to prioritize the cath lab and revascularization. Certainly, we need to rule out mechanical complications. And I put asterisks by the hemodynamic support because, again, we have some observational data, we have some randomized data, and at the end of the day, you have to apply your clinical judgment because, as you heard in the first talk, we don't have guidelines, and we have to do what we think is best for the patient. It's on the background of that we're now being asked to develop randomized trials. So how do you do that when you're dealing with a sick patient who's dying? Well, it has been done. There have been some randomized trials. I'll go through this very, very quickly because I think many of you are familiar with this. This is sort of the grandmother of all the trials, shock trial done by Judy Hockman, patients with cardiogenic shock from either non-ST elevation MI or ST elevation MI, what used to be called non-Q-wave MI. I'm sort of dating myself with that terminology. But interestingly, when they were randomized to revascularization versus medical therapy, there was no difference at 30 days. Which is really interesting because you may note in some mechanical support studies the same thing. There was no difference at 30 days. So maybe 30 days is not the right endpoint we need to be looking at. Maybe it should be longer term. Because when these patients were followed out to 10 years, that's when you really saw the difference. So maybe there are still some issues that patients are dealing with at 30 days that maybe that's not the ideal time point for a randomized trial. What about CULPRIT shock? You heard about this. You know, before the CULPRIT shock trial came out, it was a class 2B recommendation to perform multi-vessel PCI in a patient with shock. The idea being that when you open the culprit artery and they had other coronary disease, maybe that was compromising and causing more ischemia, so opening those vessels potentially could help the patient. In this trial, again, very simple question, it didn't seem to help. In fact, these patients did a little bit worse. They had worse death, they had worse renal replacement therapy, and worse bleeding. Now, for those of you who may be thinking about this, contrast that with the STEMI patient who doesn't have shock, where multivessel PCI is helpful. Interesting dichotomy. Why is that? Well, we have to think about trying to understand what those differences are. Again, we've seen some of these data already, the milrinone versus dobutamine, so I won't repeat it, but just to show you that there is a way to do randomized trials in cardiogenic shock. We just have to commit to it. Why do we use norepinephrine versus dopamine? Well, this is an interesting study looking at shock. Only 280 of these 1,600 patients had cardiogenic shock. But in this particular study, when you teased out the different subgroups, norepinephrine was associated with a better outcome than dopamine in the patient with cardiogenic shock. So, you know, I'm kind of an old guy, you know, I've been doing this for a little while. My first reflex is to reach for dopamine, but I have to remember that the evidence doesn't support that. The evidence supports the use of norepinephrine if vasopressors are what is under consideration. In terms of mechanical support, very, very challenging to do trials with mechanical support. Holger Thiele has really been the one who's been able to do this in Germany. The IABP Shock 2 trial, the BESIS trial is the other one in the United Kingdom, showing similar outcomes. In patients with cardiogenic shock and ST elevation MI, no difference between not using a balloon pump and using a balloon pump.
So the European guidelines have downgraded the use of balloon pump, and in fact, Holger has shown that the use of balloon pump in Germany has plummeted since the publication of this study. What has happened in the United States since the publication of this study? Not much of a change, really, right? We tend to like our balloon pumps. They're easy to put in, they're 8 French, they're available in community hospitals. What did the data show? Probably doesn't matter to us, so we're just still using them. Now, I'm not that pessimistic. It took 200 years for the British Navy to put limes on their ships, so we're a little bit better than them so far. We've got a few more years, but we do have to start paying attention to the evidence and trying to generate what those data are. Here are the trials of the intravascular microaxial flow pump, the Impella device. You can see there are a couple of things. Most of these trials were discontinued because of lack of feasibility. People were unwilling to randomize. Some of them were completed but had very, very small sample sizes. So these trials that were completed suffer from type 2 error. They're just too small to show a difference. So I think this underscores what the challenge is in cardiogenic shock trials. You know, it's not industry who's not willing to fund them. It's not that the patients aren't there. It's that we are unwilling to randomize. So it's incumbent on us, if we want to get more data and we want to get guidelines, we have to be the ones who are willing to randomize. But it's not so easy. It's easy for me to stand up here and say it. What are the challenges? There are multiple etiologies of shock. So we have to define a clinical trial population. What are the inclusion criteria for these patients? A patient with acute MI and shock is totally different from a patient who's had chronic heart failure and comes in with shock. You know, it is relatively low prevalence. I mean, we are dealing, most of the MIs that we deal with do just fine. It's the patient that comes in shock that everybody talks about the next day, right? So it's a relatively low prevalence. So how do we get enough patients enrolled in these trials? Well, my idea, I think, is we should develop these large networks, some of which are already happening, like the NCSI, Cardiogenic Shock Working Group, and use those as a platform for randomization. The American Heart Association is starting a cardiogenic shock registry, and we are building that specifically with a dimension that will allow us to randomize within that registry. This is something very similar to what oncology has done and has been very, very successful with. These networks where patients automatically get enrolled into these randomized trials. Funding is a challenge. The devices are very expensive and the funding may not actually cover the costs. So for example, in the state of North Carolina Blue Cross Blue Shield will not pay for a single penny of hospitalization for a patient who's enrolled in a randomized trial. So that becomes a very limiting factor for us to try and enroll patients. And so if we're going to try and randomize patients into one device versus another, is the National Institutes of Health really going to pay for that? That's very tough, right? Consent is a huge problem. How do we get consent for these patients? And can we waive consent or get some kind of short form consent or proxy consent and get full consent afterward? This is a strategy that's been tried in Europe, for example. In fact, in Europe, for one of the randomized trials in PCI and antithrombotic therapy, patients were randomized to 2 accepted antithrombotic therapies, and actually consent was completely waived because the reality was if the patient presented on a Tuesday, they'd get one because one particular interventionist liked a certain type of antithrombotic therapy. But if they presented on Wednesday, they'd get a different one. The idea being that the randomization was going to occur regardless of when the patient presented. That is not the strategy currently in the United States, of course. And the FDA does have some guidance on emergency consent, and for example, particularly with cardiac arrest trials, there's a precedent for certain creative ways of getting consent. But patients who are unable to consent really present a challenge for IRBs and for ethics boards. And then the bigger one is equipoise. And we talked a little bit about this during the panel discussion, but I'd like to hit on it a little bit more. How do you, when you're faced with a patient who is dying in front of you, have equipoise to randomize to one versus the other? Particularly when, in our own experience, we may have seen one strategy work and another strategy not work. This is very similar to what happens in large practices. If I have experience with one device and I remember that last week it worked great, and I remember yesterday I put a different device in and I had a big complication, I'm probably going to be unwilling to randomize to that device that I got a complication from. So we have to figure out a way to separate ourselves from our own lack of equipoise so that we can actually get data to guide our practice. How do we do this? I think we need some kind of potential change in the paradigm of how we do randomized trials in the United States to try and overcome this. And then, of course, there's the challenge of treatment crossovers. This gets a little bit what Dr. Boskert was saying. Shock is a very dynamic thing. A patient may come in and initially require very little mechanical support, but then a few hours later, they may require really robust mechanical support. If we're doing a randomized trial that randomizes one versus the other and you have treatment crossovers, that dilutes your sample size, it dilutes your statistical power, and again, you suffer from type 2 error. There are ways to deal with that when you design trials, but most sample size calculations take into account about a 5 or 10% crossover rate. If you're dealing with a 30% crossover rate, then you're really, really diluting your statistical power, and chances are you won't find the answer. So we've got to figure out how to deal with these treatment crossovers as well. Now, I'm not pretending to have any answers, but I know that we've got a really, really smart panel, so I expect that by the end of this session, we will have solved all of these problems, and then we'll all be ready to go out and start randomizing people. Until we have more data, I'd like to point out this particular study led by Tim Henry, who's sitting in the back there. Whoop, I think I may have gone too far. Are you able to go back one or no? If not, it's no big deal, but there is a statement from the American Heart Association led by Tim Henry, who's sitting in the back, that talks a little bit about the different types of cardiogenic shock that patients present with and the different strategies that you can use to try and deal with them until we have more randomized evidence. So again, thank you very much for the invitation to come here. I'm delighted to be here, and I look forward to the panel discussion.
Sunil, excellent talk. I have a lot of questions, but I'll defer to the panel to begin.
Thank you so much for the terrific talk, and I think you really highlighted the main challenges for us in RCTs and cardiogenic shock, and based on actually the discussion which transpired in the first talk, wanted to add to the crossover part. Yeah. I think one issue also is that when you think about randomized controlled trials, you think about one intervention. The patient comes with the STEMI, and the vessel is occluded, and the intervention is opening the vessel, and then the intervention is done, and the patient goes his way. And I think, as we rightfully noticed, that cardiogenic shock is such a dynamic disease with different speeds of trajectories. For randomized controlled trials in the setting, we should rather think about strategies than interventions. And this would also eliminate the problem of crossovers, because PIs would get options what to do when certain situations occur, and then by a multitude of trials, these strategies would refine over time. I think that would be an important aspect to consider.
Yeah, I think you're absolutely right. I think strategies are the way to go. But the other potential solution to this is to do cluster randomization. So you actually randomize sites rather than patients. Now, the analysis is still at the patient level. So cluster randomization is, we get a group of sites together, they all decide that, strategy A and strategy B are both reasonable. And then you randomize the sites to either do strategy A or strategy B. Now, the success of those depends on how adherent each site is to their assigned strategy. So you really have to have sites that are going to be committed to it. But it allows for a little bit of nuance in the way you take care of these patients, because you have a protocol in place rather than one treatment versus another. Yeah.
Absolutely. Although I would like to add, the one problem with cluster randomization is that hospitals tend to be so different in the kind they get their patients. And I think we sometimes see that when we do like multi-center registries on patients, and some centers tend to have like a shock mortality of 20%, which probably is because they get referred patients and there's a certain selection bias. But I mean, obviously with a big number of hospitals that would be accounted for, but this disease is so heterogeneous and so different trajectories that I think this needs to be factored in.
Yeah, no, I totally agree, and I think it depends on how you choose your sites.
Absolutely.
And I'll just say, again, just like Nir, I'm an optimist. So I think that it's important that as we start thinking about these kinds of challenges, that when it's important not to get sort of bogged down in the nihilism of how complicated this all is. I mean, it's supposed to be hard, right? And that's why we should do it.
Sunil, if you wanted to develop your perfect shock clinical trial, what would that be?
Yeah, so we actually did submit what we thought was a perfect clinical trial to the NIH, and they didn't agree with us, interestingly enough.
That's why you have the panel.
No, so we actually had we submitted an application to the NIH to do a strategy trial of two different approaches to patients who are presenting with acute MI cardiogenic shock, actually two different escalation protocols. So we actually had specific milestones built in. The initial strategy would be X versus Y, and then if patients were to deteriorate, they would continue to escalate. The challenge with that, as you can imagine, is that mechanical circulatory support necessarily has to be a part of that.
Yeah.
Mm-hmm.
And there's just no way that there's enough money to cover the costs of those particular devices. So that's one challenge. But I think that would be my perfect trial is, you get a group of really, really smart people together, like the folks on this panel, and you say, what are 2 different reasonable strategies to treat patients with shock, and then randomize to those different strategies.
I have a question. Somewhere I read a beautiful definition of religion. It says what you do after you've finished your prayers is religion. Shock is the same thing. We are talking about how to stabilize the shock, but that in itself cannot be the treatment. The outcome depends on what you do after you've stabilized the patient.
Yeah.
That just gives you time to stabilize the patient. After that, how good a revascularization you've done, how good a valvular change you've done, or a transplant, whatever else, that will define mortality, that will define survivability. And that has to be factored into any of the trials. Here we are focusing and trying to freeze, okay, we've treated shock, is the patient alive or dead? All the patients will be dead if you don't do anything after stabilizing the patient.
I think it's a great point. I totally agree with you. I guess perhaps my perspective is that maybe that's the next step. So you've got to start somewhere. And we have some basis on which to actually build on some of the previous randomized trials that have been done. You're not going to answer all the questions with one study. But I do think that you got to start somewhere. Yeah, Begum, I think you were...
I want to bring the perspective of intersectionality with existing data and guidelines from etiology.
Yeah.
So, SCI-C, stage D heart failure, right? Stage D heart failure, yes, mechanical circulatory support or advanced therapies. We already have that gestalt and thus can't randomize. So the ethical boundaries of what do you do, depending on the etiology, sarcoid VT shock versus PE shock versus myocarditis shock versus heart failure shock. So I totally agree with Biswajit in the sense that our probably approach to this, a wide range of different perhaps entities that end up in shock is strategy. Not necessarily specific recipe, because the recipe will depend on the etiology, the trajectory, and the dynamic change, and look for maybe looking at crude concepts of whether you're going to stay at your center or you're going to go to another center with advanced availabilities where they're going to decide what's the right strategy. Once we figure that out, then we'll be able to figure out what needs to be done once that's built. I think currently when we look at the post-MI shock, that was a certain specific phenotype. Yeah. Now we're trying to embrace everything with just hyperperfusion and end organ damage. But then the etiology really matters.
No, I think you're absolutely right. And that's where designing that trial is going to be really, really important to make sure you have your inclusion-exclusion criteria set specifically.
Dan?
Sunil, I think there's one point that you made that needs further discussion, which is that we have the IBP 2 shock study, but yet balloon pump is still number 1. Yeah. What does that mean? And what does that mean if we don't like the result of a clinical trial, we ignore it? What if danger shock is negative? Yeah. What if Holger's ECMO shock is negative? Yeah. What is it we have here? You ask for a trial, you get it, and then we ignore it. What does that mean?
Yeah, so it's a great question, Dan, and I think it's something that we've been struggling with, not just in cardiology, but in medicine, right? Which is that, we tend to have our decision-making influenced by multiple things. It's not just the randomized trials. I mean, we're all smart people. We try to do the right thing. It's also based on our gut evaluation of the patient that's in front of us. And again, the randomized trials help to guide us, but they really should be just part of the decision-making process that occurs. I think it's easy to get a little bit cynical when you start thinking about the fact that we have randomized trials and no one's, it takes a while to get those things adopted into clinical practice. We went through this, for example, with radial access, 19,000 patients in randomized trials comparing radial versus femoral access. And the rate of radial approach is now above 50% in the US after 15 years. So it takes a long time for people to digest that information and to have it influence clinical practice. I'm sort of avoiding answering your question because I think that what does it mean about us? It means that we're irrational creatures. That's what it really means. And
I think what it means is that everyone has had patients where the balloon helped, and you hang on to those things. And I'm just concerned that shock may be a disease that you cannot have a positive randomized trial. because of all of the things that were discussed. You know, the variability, the time sensitivity, all of these things. You know, when are you starting? It may be a condition that is not possible to have a positive trial. You know, the danger shock trial, which has been going on for 6 years, probably, you know, is going to be very, very telling, because they're really being very careful to try to enroll, you know, a very specific type of patient. But, you know, 6 years and maybe another year and a half to go, you know, 7 years to conduct the trial. And then if it's negative, people are just going to say, well, my patient doesn't fit in there, and I'm just going to use Impella. So what are we doing?
No, so I think you're actually underscoring a really interesting point about randomized trials and where they need to go. Remember, randomized trials give us the average effect, right? Our challenge is to apply that average effect to the patient in front of us. You know, in a current era where we've got all this big data, we've got abilities to profile individual patients, we need to graduate our randomized clinical trials away from the average effect to some kind of individualized treatment strategy. And the second comment I'll make is that danger shock has been going on for a long time. It started out as the Dan shock trial in Denmark and then added Germany. They have about a year and a half left, but they can't add any more countries because it'll screw up the acronym. Right? You could add the US because then it'd be dangerous shock. But other than that, that's it. It's over.
All right. A really fascinating discussion. Thank you. So.